we have no disclosures. As you all know, angiomiolipoma is a benign renal tumor. It's not very common, and 1 to 3% of all renal tumors. And well, keep in mind that there is a subtype of angiomiolipoma that is not so benign, and it has very aggressive behavior, poor fat, and it can present with local invasion and metastasis, and it must be treated as a renal cancer and not as an angiomiolipoma. Two main groups, sporadic and tuberous sclerosis complex. These ones are larger, they grow faster, they are bilateral and multifocal, they present earlier, and they have a higher complication rate. And 80% of tuberous sclerosis patients will present a renal angiomiolipoma. The clinical presentation, most of them are symptomatic, as an incidental finding in imaging studies, when the symptoms are flank pain, compressive mass effects, and hematuria, and the presentation as a retroperitoneal hemorrhage leading to a hypovolemic shock. And this one is the main goal, to avoid the MLA complications and the main complication that is the retroperitoneal hemorrhage. And we have to do that trying to preserve as much as renal function as we can. So classically, the risk factor was the tumor size, more than 4 centimeters. But there is a lot of controversy with this issue. There are a lot of presentations about that. So we have this one of Kusk that show that 74% of the bleeding was in tumors more than 6 centimeters. Sorry. Another presentation with an active surveillance management showed 30% requiring active treatment, just 2.3% rupture, and they conclude that the cutoff of 4 centimeters leads to 67% overtreatment in symptomatic patients. So we need to look for another risk factors more than the tumor size. This is another work showing that the intratumoral aneurysm is more than 5 millimeters is higher specificity if we compare with the tumor size of 4 centimeters. In the same direction, this work with BAT, they show that the growth was really uncommon for angiomiolipomas, and only 9% are growers and are independent of the size of the time of diagnosis. And they conclude that lesions that more than 4 centimeters do not require early intervention if we are basing just in tumor size. Another risk factor is pregnancy. All MLAs are estrogen subtype receptors. They have very high incidence of rupture, and there is a scarce of evidence and very few publications showing significant fetal mortality and 1 maternal death reported. So keep in mind, it's not just a question of tumor size, other risk factors, growth rate, pregnancy, genetics, and the intratumoral aneurysms. And that is important for the management we have to do with these patients. In this presentation of Hatano, they proposed this algorithm. In symptomatic patients associated with tuberous sclerosis, the first-line treatment, mTOR inhibitors, and second-line embolization, surgery, and ablation. Symptomatic in sporadic cases, embolization, surgery, and ablation for selected cases, and the asymptomatic ones, tuberous sclerosis associated, the threshold was with 3 centimeters tumor size for deciding if it's active treatment versus active surveillance. With sporadic, the tumor size more than 4 centimeters, and they include the intratumoral aneurysms more than 5 millimeters to decide whether to go to active treatment or active surveillance. New publications from last year is very interesting because they separate the emergency clinical scenario that goes to selective arterial embolization from the other part, symptomatic ones leading to active treatment and asymptomatic introducing all the risk factors: lesion more than 6 centimeters, aneurysm more than 5 growth, and childbearing age. This is an emergency care case with huge angiomiolipoma with active bleeding. You can see dysmorphic blood vessels with active extravasation and the treatment with glue. So which is the best technique. We all know that embolization is very, very effective, not only in controlling hemorrhage, but also in treating symptoms and reducing the volume of the tumor. The recurrence rate publicated are high, but remember this data is very old and the last publication has a lower recurrence rate. And we also know that embolization is very safe. This is another case, typical image. Sorry. And the result treated with glue. So last words to talk about embolic agents. Also the same problem, weak evidence. We don't have enough publications to say which is the best one to treat the angiomiolipoma. The ethanol was very popular in the past. It's very potent, but has a high complication rate. Coils, I would not recommend using coils as the first line of embolic agents for treating angiomiolipoma. No distal ischemia, and the problem is you can occlude bleeding vessels, and the secondary treatment will be much more difficult. PBA has the problem of aggregation with high recurrence rate and no touch embolization. That problem is solved with microspheres, no aggregation, and they provoke distal tumoral ischemia, but the problem is more expensive. Cyanogen glass, which is the one that we actually use, it's a very quick and cheap agent. It's very visible, it's adhesive, has good results, and it's adaptable, and you can decide depending on the speed of the blood flow with the mixture with lapiodol. And the problem is non-controllable, and you need some experience for using it. Also publications with onyx, safe and effective, distal and proximal embolization, and the problems are the procedure is more painful, and the artifact they provoke is a problem for the follow-up. This is one of the latest articles I have found is from this month, and well, we were demanding prospective randomized studies, and I found this one. It's comparing PBA with a mixture of lapiodol, bleomycin, and glue, which is not very familiar for me for treating the angiomiolipoma. In both groups, no major adverse event and technical success, and best results for lapiodol, bleomycin, and glue in hematuria, flank pain, reducing the volume, and recurrence rate. So take-home points. Remember that tumor size is not the only risk factor. You have to consider two different entities, the sporadic MLA with the TSC MLA. So you need to individualize the management. Remember, initial active surveillance is a possibility for treatment of asymptomatic MLAs with no risk factors. And despite we need more evidence, embolization is safe and effective as a first-line treatment, and no enough evidence of superiority of any embolic agents now. So we need prospective studies to compare all the different treatment strategies. Thank you very much.
Thank you very much for this very nice talk. When I was treating AML, and they're getting bigger and bigger, and the pseudoaneurysm are rising, increasing, 3 mm, 4 mm, 5 mm, my hit point, my target point was always the pseudoaneurysm. So I always used glue, the old glues and then the newer glues. What do you think? From the point which we have to hit in the AML to be safe that this will not bleed in half a year, what is your goal? What is your technique?
Well, I agree with you. When we perform the CT, we are always looking for the vessels, for these aneurysms that are inside the tumor. And I think that's the most important thing, because the goal of our treatment is to prevent the rupture and the retroperitoneal hemorrhage, which is the really life-threatening condition. So when you have an aneurysm more than 5 millimeters, you have to consider that independent of the tumor size. So that's my opinion. Yeah, we use glue also, and it's what we're using right now. And in the past, a long time ago, we used particles, PBA, and we have high recurrence rate that we actually don't have now.
And many questions from the audience are about glue. Which ratio are you using?
Well, we talk glue, but there are several types of glue, and you have to separate the three of them. So it's not the same Acryl, that glue brand, than the magic glue. We actually use glue brand now, and well, it's different. So you can't put glue all together, because there's a difference between Acryl, that is a higher exothermic reaction with a lot of more inflammation and cytotoxicity than glue brand.
One question is very interesting. The colleague is asking, if you have the patient with had bleeding AML, but now it's stable and he comes to you, what is the best moment now to perform embolization? As soon as possible?
Well, I think we have to look to individualize the treatment of the patient, because we have talked about all the risk factors, but you have to sit in front of him and explain what's going on there, and the risks of the treatment and the risks of performing an active surveillance. And you also, I think you have to watch what kind of patient do you have. If they is going to understand a follow-up, an active follow-up, or not.
You stressed in your talk the difference of the AML. We have the spontaneous type, and we have the one which is correlated with TSC. In your embolization technique, don't mind indications, in your embolization technique, do you do any difference between these two types, or are you treating both in the same technique?
No, we are treating very similar, both of them.
Then I have to thank you for your talk, and we come to the last speaker.